So welcome. In today's session, we'll be discussing about um, medium vessel vasculitis. This is the first part. I will also do a second part. But in today's session, we'll be discussing about polyarteritis nodosa. So polyarteritis nodosa, PAN, okay, PAN, pan, okay, not your cooking pan. Polyarteritis nodosa. Welcome all. My name is Boris Manyeri and I'm the director. Now, when we were discussing about classification of vasculitis, we said you can classify it according to the size of the blood vessel affected. So we had large vessel vasculitis, we had giant cell arteritis or temporal arteritis, and Takayas arteritis. The name of Takayas arteritis is Passless disease. Then you have medium blood vessel vasculitis, which we'll be discussing today. We have PAN, polyarteritis nodosa, Kawasaki's disease, and Buerger's disease. The name of Buerger's disease is thromboangiitis obliterans. Then you have small blood vessel vasculitis. They can be either ANCA associated or non-ANCA associated. ANCA is the anti-neutrophil cytoplasmic antibodies. And those antibodies are of two types, P ANCA and C ANCA. P meaning perinuclear, okay? And recently they are also known as MPO ANCA, anti-myroperoxidase, anti-neutrophil cytoplasmic antibodies. And they are found in microscopic polyangiitis and the Churg-Strauss syndrome or vasculitis. Then you have the C ANCA, which is now also known as the PR3 ANCA, anti-proteinase 3 ANCA. C means cytoplasmic. Now, they are found in Wagner's granulomatosis, or also known as granulomatosis with the polyangiitis. Now, let's get to polyarteritis nodosa. And now, PAN, it is a systemic vasculitis of small or medium-sized muscular arteries, note that. Now, it mainly involves the renal and the visceral vessels, but of interest, it spares the pulmonary circulation, okay? Now, even if there is involvement of the renal vessels, there is no glomerulonephritis. Now, it has no association with ANCA, okay? Then in 30% of the patients, they have chronic hepatitis B infection, and this will lead to the formation of immune complexes, the antigen antibody immune complexes, which are deposited in the affected vessel, okay? Then in the other two that the cause is unknown. Now, polyarteritis nodosa is the commonest cause of mononeuritis multiplex. That can be a very good MCQ. Now, let's look at the morphology of this polyarteritis nodosa. Now, it is a segmental transmural necrotizing inflammation of small to medium-sized arteries. And this is often superimposed with there is thrombosis. So there is that transmural. So all the three vessel wall layers are affected with this necrotizing inflammation, and there'll be a thrombus in the lumen. Now, the most affected vessels are those in the kidney, then in the heart, then the liver, then in the GIT, okay? Regions usually involved, the regions usually involved only part of the vessel circumference and have a predilection for the branch point. So this polyarteritis nodosa will mainly, that inflammation will mainly be found at the branch points, okay? Now, impaired perfusion due to this vasculitis, due to that superimposed thrombosis, which can lead to distal ischemia, that may lead to ulceration, infections, ischemic atrophy, or hemorrhages in the distribution of the affected vessel. Now, the inflammatory process may also weaken the arterial wall, and weakening of the arterial wall will lead to aneurysms. And these aneurysms, especially the pseudo aneurysms, might rupture, okay? And that can be catastrophic. Now, in the acute phase, so this polyarteritis nodosa has an acute phase and now like a chronic phase. Now, in the acute phase, there is a transmural mixed inflammatory infiltrate, and this infiltrate is composed mainly of neutrophils and mononuclear cells, okay? And it is frequently accompanied by fibrinoid necrosis, okay? So note that, fibrinoid necrosis and luminothrombosis, Okay, now in the older lesions, usually show fibrous thickening. There will be fibrous thickening of the vessel wall extending to the adventitia, okay? And that fibrous thickening will produce the so-called string of pearls appearance on angiography, okay? Or on imaging. Now, characteristically, all stages of activity from early to late coexist in different vessels, or even you can find the same vessel. So this is the same vessel. You find in this segment, we have an early region, and here we have a late region. So here there is, in the early region, you find that transmural mixed inflammatory infiltrate. Then in this late lesion, there will be the fibrous thickening, the so-called string of pearls appearance, okay? So let me show you an image of that. You can see this is fibrinoid necrosis here, okay? You can see this is fibrinoid necrosis here. Fibrinoid necrosis, okay? Okay, then of interest, you can see this segment of the blood vessel here is not involved, but here there is an active, this is an early lesion because you can see the fibrinoid necrosis, okay? So here there is a fibrinoid necrosis. This eosinophilic area is suggestive of fibrinoid necrosis, but you can see this area here, it is characteristically free of that fibrinoid necrosis. It is unaffected. Then let me show you the string of pearl appearance. This is a string of pearl. This is a plant, okay? Then characteristically here you can see the renal artery. Okay, this is the renal artery on angiography. Then you can see this, due to this fibrous thickening in the late regions, it is producing the so-called string of pearls appearance. You can see the resemblance, okay? You can also see some regions here, okay? Here, okay? Here, the so-called string of pearls appearance. So don't forget, this is a plant, the string of pearl, the plant itself, and now the string of pearl appearance, okay, in polyarteritis nodosa. So don't forget that, okay? That is important. Now, clinical features. Now, this is a disease of young adults, but can occur in all age groups. Now, the clinical cause is characteristic. It is episodic. So there will be those episodic attacks with long symptom-free intervals, okay? Now, the systemic findings are usually malaise, fever, and weight loss, okay? And these are non-specific. And the vascular involvement is widely scattered. So the clinical manifestation can be varied and puzzling, even for an experienced doctor. So now, a classic presentation involves some combination of there'll be rapidly accelerating hypertension. Why? Involvement of the renal artery. So you know, if the renal artery is affected, which will lead to occlusion, there will be activation of the RAS system, the renin, angiotensin, aldosterone. That will lead to a rapidly accelerating hypertension. There'll be also abdominal pain due to involvement of the vessels of the gastrointestinal tract. Also blood stools due to there may be an ulceration. Okay, there'll be also diffuse muscular aches and pains. There'll be also peripheral neuritis. I told you polyarteritis nodosa is the commonest cause of mononeuritis multiplex. And this will affect mainly motor nerves. If motor nerves are affected, movement is also affected, auditory movement. Now, renal involvement is often prominent, and it is the major cause of death, okay? Now, if untreated, PAN is fatal. However, we use immunosuppressants such as the corticosteroids. Those are anti-inflammatories, and also you can also use cyclophosphamide, okay? And once you use immunosuppressants, the 5-year survival rate is pretty good, in about 80%, but in a quarter of cases, it usually relapses, okay? And relapse usually is more often with the non-HPV associated cases, the two-thirds of cases, okay? Than those that follow HPV infection. Now, in HPV infection, once you treat HPV, the risk of relapsing will decrease. Now, those which are due to HBV infection, they have a better long-term prognosis, okay? Like those of non-HBV. I think that's that. It was that easy. Thank you for your attention, guys. And follow for more med content. Next, we'll be discussing Kawasaki's disease. Stay tuned for that video. Thank you very much.